So before we start, just a couple of disclaimers about this talk. Despite the best efforts of Matt, Seb and Julian, I just wasn't able to get my head around the neurophysiology associated with all of this stuff to such an extent so that from now on there's going to be no further mention of calcium ions or the spinothalamic tract, because as I was trying to do this stuff, the fog that was building in my brain around the construction that happened there just said that, look, this stuff is not possible for me to be able to show you in a clear way. What you do have to take a little bit on faith, though, is that the stuff I'm going to present is based on solid neurophysiology, although I won't present all of it here. And the papers that I'm going to draw your attention to are exemplar papers, not necessarily systematic reviews or large bodies of work. But again, you have to take it on faith a little bit that the papers that I'm presenting you are representative of a fairly large body of research. And in large part, that's because the aim of today's talk is to get you interested in this idea so that you can follow on this further, if that is indeed your thing, especially with Dr. Dijkstra's lectures that are coming up. If you are interested in this kind of stuff, I'd really strongly recommend these two texts. They're available as e-books online. They're not terribly expensive, and they really give you a terrific introduction to this whole area, and especially because they're written in relatively simple language, which is great for me, but also they're particularly aimed at our patients, and that's really the target population. And one of the recurring themes hopefully you're going to get across from here is this is all about getting understanding across to our patients. It's not necessarily about us anymore. So as background for this, and what I need to point out is I am by no means an expert in this area. It's just something I've become interested in, and why I wanted to talk about this was I wanted to tell you about how my journey towards this area happened. In the last couple of years of my undergraduate life in the 80s now, back pain was the biggest deal and remains the biggest deal, and I decided that was the thing I was going to get involved in. And so I directed all of the end of my undergraduate career towards learning about back pain. And immediately on graduating, I literally went to every possible course I could see in back pain. And unfortunately, my experience represented that of the wider community, or the wider medical community, in that while our management of these disorders was generally getting better in other areas, in musculoskeletal, but especially driven because of back pain, the burden caused by it was getting worse. And frankly, when I was looking at myself, I thought that I'm actually making things worse. I'm genuinely not helping any of these patients that I'm seeing with back pain, was my estimation of the whole area. At around about the same time, I happened to be working in a sports medicine clinic, and there were these orthopaedic surgeons and sports physicians who were looking inside joints and identifying pathology and injecting things that they saw in imaging, and their patients were getting better. So I literally walked away from back pain and went towards sports injuries, where we've got this structural pathoanatomic model that to my mind worked perfectly well, and all that we had to do for all these patients was actually go and find what was physically wrong, and we could fix these guys. And so in the ensuing decade or so, while I watched this research happen up through to the mid-2000s, I saw, yep, that was a great decision to get out of chronic pain, back pain, because really we're just not helping these guys. And there was a real split mirroring kind of my career, that the chronic pain stuff and the sports medicine just completely forked, and we've really had nothing to do with each other. So it's really prescient what Dr. Dijkstra said at the start, and hopefully you'll start to think of some reasons why, just before an Olympic event, or just as the stresses really start to rise, that your athletes are going to suddenly complain of pains that you just can't explain and help, and that these pains might change to do with things not related to structural pathology. So these chronic pains, as I was saying, were increasing despite the fact we were doing more surgeries, we were doing more injections, we were getting more imaging, and we were administering more analgesics. And what I hope to get towards you at the end of it is, at least in part, the reason the burden of this disability was happening is because we were doing all of these things, none of which relate to the actual pathology itself. So here's the plan. Here are the things I want to try and get across to you. We want to try and understand that there's a very tenuous, precarious, and probably even absent link between tissue damage and what patients perceive as pain. I want to talk about measuring pain, and I think I'd invite you to say that the ways we've classically been doing it are wrong and not helping our patients. Pain is all in your head, but never ever tell your patients that, because they're going to walk out straight away. And we really need to reconceptualise pain rather than a sensation like hot or cold, although hopefully at the end you'll realise that they are basically the same thing. Pain is actually a behaviour, not necessarily a sensation. So here's the motivating case. Let's consider this guy who's playing in our national team. He's come here from another country. He's had maybe half a dozen previous episodes. His pain's now significant. It's stopping him from training and playing, and there's a bunch of different things aggravating it. After expert examination, our classic pathologies have been excluded. And so if we look to the research here, we'd say that this guy fits into our diagnostic category of saying he has patellofemoral pain syndrome. But really we could have done this for anything long-standing pain where we can't come to a definitive, discrete pathoanatomical diagnosis. And that actually fits a surprisingly large amount of the things that we're going to talk about. So what could we do for this guy? When I sat down to decide what would be the potential list of things we could do, I'd say, well, probably we'd measure his pain during the different things that he's doing. We might do some sort of functional measures as well. And then I think we'd be entirely justified to do any or all of these interventions for this particular guy. And what I want you to think about during this course, and we'll revisit this towards the end, is to start to think about, well, how many of these things are appropriate, or is the way that we're delivering these things entirely appropriate for our athletes? So thing one, how much pain does the guy have? That's typically our measure as to, are you getting better or worse? And by and large, we do this with a thing called a visual analogue or numeric rating scale, where we ask our patients from 0 to Walla, coach, it hurts very much, how much pain do these people have? And if you look to the research, by and large, all of the research is conceptualised within this framework as well. I've taken this example because it's from our area of dry needling, but you could equally do it to any intervention that's directed towards pain. So if you like a lot of harried and rushed clinicians, you might look at the title of this paper from the Journal of Orthopaedic and Sports, and you say, oh, right, dry needling for upper quarter, yep, I need to have a look at this, and I'll jump to the forest plots, and yep, looks like there's a clear short and medium term effect going on here. What do these guys say in the abstract and in the conclusion? Right, we've got grade A recommended for compared to sham, or okay, so this intervention works. I think we'd agree on the basis of the evidence, and if we're going to be evidence-based, we'd say you're entirely justified to make this intervention for pain. If we look a little bit more closely, though, at the forest plots, and part of the reason that, in my opinion, and we've talked about this before, that p-value stands for pointless or puerile, is that if we look at the size of the effect that's going on here, on a VAS, this is 1 out of 10. At what stage was how much is this pain change important to the patient considered? And by and large, that's never considered, at least not in sports medicine, not in the areas that we work in. But the pain science guys for the last quarter of a century have been really focused around this and trying to generate their evidence as far more patient-centred rather than clinician or output-centred. Or, as we like to say, we're measuring the measurables, not measuring the things that actually matter. We're just measuring because they're easy to measure. So this is, I think, a terrific and overlooked paper from nearly 15 years ago now, where these guys took a whole bunch of different people who had long-standing pain, and depending on whether their baseline pain was 4 up to 9 out of 10, they had a range of interventions that changed their pain, and they asked them to change in pain from 0 to 10. So if the pain went up, their pain was getting worse. If the pain went down, it was getting better. And if we look at our 1 out of 10 change in pain that we saw from dry needling, as far as patients are concerned, that ranks somewhere between no change and minimally improved. And in fact, a 1 out of 10 change is closer to no change as far as a patient is concerned. In fact, if you reduce their pain by half a point out of 10, they'll say that they're no change, or actually they got a little bit worse. And yet, if we have a large enough sample size, that'll be strongly statistically significant, p less than 0.01. So we demonstrated a statistically significant reduction in pain with this intervention. Yeah, and the patient thought they were no different, or they actually got a little bit worse. So the first message we need to take home about this is, sure, continue measuring pain on this scale, but in a practical sense, we really need to be asking our patients, are you a little bit better, a little bit worse, no different, lots better, lots worse, and conceptualise the outputs in that regard. Because an improvement in pain that you might consider a minimal improvement in pain needs to be factored into the context of, for example, something that's very low risk of a downside. I'm going to give you this sheet to read, as opposed to we're going to have to engage in this surgery, for example. Are you prepared to take that risk given that this is what the potential downside necessarily is? Same outcome in both cases, but what's the impact for the patient? The next thing, and the kind of central part of this talk, is thinking about this concept of nociception, or the sensation of tissue damage versus pain. And René Descartes was probably the guy who originally formalised this, and by and large, as far as I'm concerned, most of us still think this is how it works. There's some tissue damage and it's somehow carried up through some tubes into the brain, and a bell is set off, and the size of the bell that's set off is according to the amount of tissue damage that goes on there. At least that's what I thought until I learned about more of this pain science stuff. But if we think about how our sensations generally work, and while most of us think there's some kind of sensory input, this gets kind of played around a little bit with the brain to make sense of it, and then we feel that sensation. If we place that into a real world context, for example, most of us think of this like, well, there's stuff going on in the engine and out through there, and we're going to get some kind of reading back from it here on the dashboard, and it's going to tell us how fast our engine's going, or what our temperature is, or how much our hydration status is, so that when our hydration goes down, we'll end up feeling thirsty. Our temperature goes up and we end up feeling hot. But if ever you've done some of Seb and Julian and Matt's crazy experiments, strange things seem to happen. Like, I walk out of the heat chamber with a core temperature approaching 40 into the air conditioning and feel cold and put my jacket on. But I'm not cold. I've got a core temperature of nearly 40. So here it's clearly gone wrong. And I've lost 5 litres of water in the last hour of sitting around doing there, and I drink 500 mils and think, oh, that's it, I'm totally stuffed. There's no way that I'm rehydrated. So there's something seriously going wrong with the inputs here and my perceptions, and more importantly, my actions. I put the jacket on despite I was really hot. I said, I can't drink any more, even though I was clearly still dehydrated. An easier example probably for us to think about, and one that's going to lead us into one we'll talk a little bit about now, is vision. And you'd remember from high school biology that the lens vertically reflects any images that we see, so that landing on the back of your retina, the strawberry's at the bottom, the cone is at the top, and then we all realise that that's not really how it works. It gets up into our brain here, and we're able to flip it back around, and we can completely understand what's going on. So we understand, at least at some level, that it's not just about photons bouncing off your retina and sending an electrical signal up to your brain. There's some kind of processing going on there. And here, some visual illusions can really help to try and point this out. If you've seen this one before, you know the talk, but if you haven't seen it, you probably don't believe this, that this grey and this grey are exactly the same colour. And if you don't believe it, as I mask that out, the remaining area, you're going to think that I'm doing some sort of trick with the graphics. But now, because there's no shading to change your perception of what's going on around those different greys, these look the same. And yet when I remove that dark colour away from there again, you'll swear, black and blue, that this one is darker than this one, unless there's something seriously wrong with your perceptual system. Or if we take a different example, are these two pictures, do you think, the same or different? Do you think these lines are parallel, the tram lines of this Barcelona tram, or they're different? To me, they look really quite different. This one looks to be heading off much more towards the side. However, if I just swap them over, you'll see they're exactly the same picture, and really what you perceive relates far more to the things that are around it. Despite the fact I'm looking here, it looks different depending on what's over there. So it's not just about photons bouncing off your retina and being represented on your dashboard here. The one that I love, though, and the one that I still have trouble getting my head around, is there's a pretty strong body of research that says we humans can't see this colour blue until the society that we live in has a reason to see the colour blue. And typically that's because we can make that colour, or that colour is somehow otherwise important to us. How this research came about initially was looking at some of the ancient Greek texts, which we in rehab are all forced to read now. And the guy who was the first researcher in this was also 4-time British Prime Minister Gladstone, who was at the time MP for the University of Oxford. And one of the things he did was just go through and count the number of times the different colours were mentioned during Homer's classics. And it turned out the colour blue was never mentioned. Well, how can that be? The entire Odyssey is set here. The time that he does talk about the ocean, he describes the colour as porphyrios, which my Greek colleagues reliably inform me means blood red or ruby red. So as far as the ancient Greeks were concerned, this was closer to the colour of red wine than it was close to the colour blue. Inspired by this research, a guy I couldn't find a photo of, Lazarus Geiger, later went back and looked at a whole bunch of ancient texts and found that always the first colours, or shades in this case, to be described are blacks and whites, and blue is always the last colour that's described in any community. That is, communities that need to have the colour blue. So there are still what we'd call primitive civilizations living on the world who have no need to see blue, and so they don't. So this paper in Nature looked at tribesmen of Papua New Guinea, and the same researchers, I'll talk about this paper even though it's not in as good a journal, it's the same researchers, but I'll talk about this one because I've got some nice video clips of this. Looked at the Himba. It's a tribe in northern Namibia who have only 5 colours to 5 words, I should say, to describe colours, whereas typically in the Western world we have about 11. So the experimenter here is showing them a bunch of colours. One of the colours is different, and these people are just asked to point out which is the different one.
Okay.
So just out of interest, is there anyone in the room here who thinks one of these is different? Okay, so we've got no Himba in the room. The Himba can see a difference in this because for them shades of green are really quite important to distinguish, but they can't pick out the different one on this side. I still can't see the difference here, even when I take the eyedropper on Photoshop and look at the different RGB values. Okay, this one's different, and I now think I only see that as different because there's different numbers inside here. That's exactly the same image except I put the numbers onto that. So this is clearly not about photons bouncing off our retina at a certain frequency and reflecting what's going up on in our brain. There's something entirely different happening here that's shaping our perceptions. And one of these guys who worked in this area of linguistics, or his daughter I should say, had the unfortunate luck of being born at the time that he was studying this kind of stuff. And so he thought, why is it that we say the sky is blue? And his thesis was, we think the sky is blue because we say it's blue. So what he did was raise his daughter exactly the same in all other means. She could identify colours and she could do things, but no one was allowed to tell her what colour the sky was. And after a couple of years, he would point to the sky, you know, what colour's that? What colour's the sky? And she'd just look at him strange. And apparently she would say it was white. And then after a few years, it was white. And then eventually it was becoming black and white until quite some years later, she said, oh yeah, okay, the sky is blue. So in the tradition of experimenting on your children, which Matt has taught me, you might think that, okay, well, this stuff is all about our visual and our visual system is easy to trick, but what about our auditory system? You know, it's just basically sounds coming in at a frequency, they're going to get transmitted up. In a quiet space like this, I'm definitely going to be able to figure this out. So, well, let's watch here and listen and see what you think my daughter's saying.
Ba, 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 ba.
Okay, so you're confident of the 2 different sounds that she's making there?
Ba, ba.
Well, what I've done here is take the sound from the first part, the B for Bravo sound, and placed it under the sound F for Foxtrot. She's actually making exactly the same sound. To prove it to you,
Ba, ba, ba.
just look here now and tell me what you think she's saying.
Ba, ba, ba.
Now what she's saying.
Ba, ba.
Now close your eyes. She's making exactly the same sound the entire time.
Ba, 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 ba.
And even when you know this effect, you can't change it. Guys who've been researching this for decades still cannot perceive it any other way. So instead of our dashboard analogy, what I think it helps me to understand this, it's a little bit more like, yeah, the dashboard is there, but far more important in influencing the behaviour of the car is the driver. Should I stop for fuel? How far is it I'm going to go? How important is it if the temperature goes up high to me? How important is it if I'm low in fuel, in water level, in all of these different things? The actual readings that are coming in are really quite small in factoring into making those different decisions. The next thing we want to talk about is that, well, basically, is that the case that that's just it? You know, you have a low pain threshold and that's all there's going to be, or you're prone to getting chronic pain. And the good news here, and it was popularised a few years ago, is that what's going on inside our brain and indeed our periphery is far from set in stone like we used to think. And in fact, the firing patterns within our neurons affect physical changes within our nerves such that over time, the things that we do more commonly and more frequently become easier and easier to do at a neurophysiological level. So after time of doing something, practice, it becomes easier and easier to do. That's a good thing when we're trying to learn to play golf, but it's a bad thing as you get better and better at generating pain responses. So the plasticity of the brain we can understand and comprehend by some really lovely experiments that come back to our strawberry ice cream. Done during the 1950s, this fellow was thinking about the idea that everything is reflected top to bottom inside of our brain, and he wondered how hard would it be for our brain to adjust to that. And luckily for us, he filmed the entire escapade. So this fellow and his research assistant put these goggles on the research assistant, which vertically flipped everything that this guy saw, and then hilarity ensued. So if you do this to your research assistant, the first thing probably that you'd want to do to the guy is take him out into the park and try and poke him with a stick. Or maybe you'd let him play with some kids. But after a few days, the guy got pretty good at doing that, and it seemed that his brain had been able to rewire it. So he thought, well, I might send him out into traffic and see if I can kill him that way. And in fact, the guy could ride a bike, and within a week or so, the guy could do a whole bunch more than just ride a bike. His visual and motor systems had successfully re-engaged and reconceptualised this, that he could do things that you would think would be very difficult to do when your arm is moving exactly the opposite to the way that you're perceiving it. And once they took the goggles off, there was some readjustment to go on again. So apologies for the PowerPoint karaoke here, but Mosley and Butler, I think, state this really quite well. You know, it's not the job of the visual system to be a physical light meter, read, fuel gauge, odometer, tachometer, whatever you want. Its job is to break that information into meaningful chunks, therefore we can perceive the world and make action. Exactly the same way, the pain system is really no good at being a damage meter. Its job is to figure out how much of a threat am I in right now and what do I need to do about it. So it's far more about the balance between the threats that your body perceives and the safety that your body perceives. And what I'm going to argue is that we significantly influence that in our interactions with our patients every single time. This has been known about, there's a tiny bit of physiology, but I'm not going to go into it. Essentially, there are some differences with what's going on in the periphery that can make nerves easier to fire. And you know this if you've got much more dexterous at certain particular tasks. And what can go on at the second order neurons, which mean that otherwise non-noxious stimuli can get interpreted as noxious. These are called sensitization mechanisms, which happen both peripherally and centrally. If we think about this sensitization, and one of the ways that it commonly gets measured is by the analysis of seeing how much force somebody can put up with at a certain point before they say, no, stop, that's painful. And this is a pretty common way to measure it. There's lots of research on this. I only put this paper in because it was published on the weekend and it caught my eye. So these guys got 44 patients who had chronic plantar fasciopathy, and they measured this pressure pain threshold at a bunch of different places in their body, on the injured person, on the injured and on the uninjured side, and on healthy people on both sides. And you would think that, okay, well, fair enough, you should have a reduced pressure pain sensation at the site of the pathology, injured people compared to uninjured people, but for the rest of the body this shouldn't matter. Just by having pain for a significant amount of time, at every site throughout their body, the pressure pain threshold was about halved in the people who had chronic pain compared to people who had nothing with them. So you could basically push anywhere and these people will say they have pain. They'll also have altered sensation to hot and cold. They're probably going to feel differently about bright lights and loud noises, and these are going to be influenced by a whole bunch of different things. So again, Moseley and Butler, or Moseley in this case, really ask us to reconceptualise this. Pain is a behaviour. It's not a sensation. I'm not feeling hot or cold. Although hopefully now you get the idea that hot and cold isn't really a sensation as well. We have to take that information and decide what we're going to do about it. This has been known actually for an awful long time, and I love this paper for a few reasons. Firstly, the venerable Bostonian Dr. Beecher, in his introduction, quotes a famous French surgeon, which I think is pretty neat, Dupuytren, from about 100 and something years ago, who noticed that when he treated guys on the battlefield, they had an entirely different reaction to the same kind of damage than when he treated the civilians. And Dupuytren was prescient enough to point out that this guy on the battlefield, who really thinks he might die or be mutilated at any minute, is actually really quite happy to be in the hospital with half of his leg missing. Whereas the poor guy, who's working as a farmer, artisan or whatever, he's now obsessed by fear and misery at the prospect of a scalpel. And Dupuytren was smart enough to realise we shouldn't be surprised by the difference in results. So Beecher's paper then went on to look to try and formally document these differences by looking at 150 people who had injuries in the battlefield versus in civilian hospitals. And the pain that these guys had, depending on where the different traumas were, turned out it didn't matter, as now you might expect, rated not 0 to 10, but none to severe. On the battlefield, 5 times as many people with the similar kinds of injuries will say they have no pain. And you're much more likely when you're under those conditions of threat to feel like, hey, actually, this is a pretty good place to be. I don't need to do terribly much now. I'm happy with where I am. And if we think, well, maybe that's just what they're saying, how did they actually vote? Well, they all had narcotics available to them. And on the battlefield, only 1 in 3 would say, give me some morphine, please. Whereas 5 in 6 of the civilians said, I'm going to need some analgesia for this pain that I've got. So clearly there's a difference in the feeling that these guys are getting and how they're deciding to act, independent of what's going on with the tissue damage. And there's been a whole raft of research done into this area on thinking how what we do influences these people. So you can go and find a whole bunch of ones, but the one that caught my eye was this particular paper, which used something that they called a headache simulator. So what they told the patients, and nearly always there's deception involved in these studies, they were measuring a bunch of galvanic skin reactions and sweat rates and heart rates and blood pressure and whatnot. And they also connected 2 electrodes up to the foreheads of these people, and the wires went off into this box that looked all official, but the wires weren't connected to anything. And on the same box there was a dial that went from 10 up to 50. And the people were told, during this experiment, you're going to get some electric shocks, but you won't actually feel these electric shocks. They're special kind of electric shocks. Apparently the subjects didn't know much about electricity. But, I'm sorry, one of the side effects of these electric shocks you're going to get is that you'll get a headache. And so as the dial was flipping around, there was also a sound being played in the background. Now this dial wasn't connected to the wires weren't connected to anything except the patient. And the only thing that varied was what they were saying, the setup that they gave for this experiment amongst the different people. But in essence, it didn't matter. As the dial went from 10 up to 50, all these people's pain went up until they turned the dial down, and then these people's pain went away. And absolutely nothing was happening to these people other than, I'm telling you, this is going to hurt. Or this might hurt, in fact. So hopefully we now get the idea that really there's no link, no solid link or no useful link that we can think of between the amount of tissue damage and the amount of pain you feel during this long-standing pain. And hopefully now that maybe starts to make some sense of some other research that I'd seen before, which looked at people with back pain, and when adjusted for what we call high and low pathology, Why do you think if you have an MRI early on in your course of getting better, you actually have markedly worse disability than if we delay the MRI to later? So what are the things about just getting an MRI? That didn't change the pathology. If I have that early on and tell you that I can see some damage here and here's the cause of your pain, well, they saw it on an MRI. There's nothing much I can do about it. Clearly I have something wrong. I'm in danger. I'm under threat. And I've in fact got the evidence to prove it. Key to all of this is that patients need to understand what's going on, but unfortunately, by and large, they don't. So take, for example, this study, which just looked at asking patients to try and explain what these different terms that we use all the time are. More than half of our patients, and remember this is native English language speaking patients being spoken to by a native English speaking doctor, more than half of our patients don't know what a strain or a sprain is. And they certainly don't know what a fractured bone is. Now think about that next time we talk to our patients and we use our shorthand. The best study that I looked at in this regard was by Karen Barker, who investigated a bunch of clinicians who were assessing and treating their patients, and the clinicians and the patients knew this experiment was going on. So I'd certainly behave a bit better if I thought I was going to be measured later on finding out what the patient actually understood by the interaction that I had with them. And when I use a term that says you've had this pain for a long time, so I say chronic, here's what the patients interpreted that as. Or if I use a word that just says the nervous system is involved, here's what the patients understand by this, or at least some patients did. So if I say, for example, my ulnar nerve is getting a little bit beaten up, for example, from lots of throwing, therefore technically I have a chronic neurological condition, what have I just done to the threat behaviour of my patient? How safe does my patient now feel for me delivering that entirely accurate description of what was going on? Well, look, our patients just aren't smart enough to understand that. That's why I've got the degree, that's why I get paid the big bucks. We really can't be as patronising as we were before. Looking at this, and early on in this sort of research, Lorimer Mosley just looked at how much do patients understand, and presciently, how much do our clinicians actually understand about all of this as well. And sure enough, patients really don't understand out of the box what's going on in terms of neurophysiology. But nor do trained healthcare professionals. These were physios in this case. And in fact, if you train your patients, they can end up knowing more than untrained healthcare professionals. Luckily for us, if we take on some training, we can actually end up having pretty good knowledge of these things. Also, what's the point of just knowing about it? Well, one of the first interventions that these guys did when they were looking at this kind of stuff was say, I wonder if we just explained this pain physiology to our patients and do no other intervention. I wonder what would happen. And it turned out that if you did that, so these are people with chronic low back pain, their straight leg raise range improved, and how far forwards they could bend also improved. No other intervention. This is pain, this is how it works, this is why you're seeing pain. Do nothing else. That also, I think, helps to start to let us understand a little bit better how the placebo effect works. The placebo effect is really a pretty dirty word, I think, in our game, but its effect is seen to be really quite large. This was a bunch of different studies trying to quantify how big the placebo effect can be, and the way they did it was go back and look at the outcomes of studies for treatments which were later on shown to do nothing, or sometimes deliberately shown to do nothing. So for example, in the case of angina, if you just make a skin incision during surgery, about half to 2/3 of the people get a significant improvement in their nitroglycerin use. Up to 100% complete relief, 65% good to excellent for gastric freezing of duodenal ulcers, and I'll take their word for it that this was eventually proved to be an ineffectual treatment. George Bernard Shaw put it really quite nicely, and we've all worked with doctors like this, and we're lucky enough to have a whole bunch of them here, that it really doesn't matter what the patient is. Just being in the presence of these fantastic doctors, the patient gets better. And when I go and do that in my clinic, I did exactly the same thing. And why didn't they get better? There's something else going on that's not about exactly what they did, but about how they did it, which made the disease or anxiety incompatible with his welcome presence or her welcome presence. Broken bones have been known to unite at the sound of his voice. I love that line. But one of the things about the placebo effect that's not often investigated, and Gracely and his colleagues investigated it here. Gracely is a guy who works at a dental institution in the US and does all these horrible experiments on when people get their teeth pulled out. He was looking at what about the feelings and thoughts of the practitioner. We're all kind of aware that, okay, it's really going to matter what we tell the patient, but what about what the practitioner feels? And the basis of this study was these people had just had a wisdom tooth, I think, pulled out. So they were going to be expected to be under pain. They had a short-acting local anaesthetic to do that. And then they were going to be randomised to receive a placebo, naloxone, which I understand is a drug that blocks the effect of analgesics, and fentanyl, which I understand is a pretty quick-acting, strong analgesic. And what they actually did was a clever thing. So it was going to happen on 3 different days, and the person giving this injection was double-blinded to it. All they knew was you were going to get one of these 3 injections. But on day 1, they said, look, there's been a mix-up, and the fentanyl hasn't turned up, the analgesic. So we can still carry on the study. Today, you're either going to be giving your patients the placebo or the naloxone, but tomorrow they'll be getting, one of the remaining 2, and the next day they'll be getting the last one. So don't worry about it. We can still do this study. So the only thing that varied was what the person doing the injection thought might be in the needle, and they weren't being told anything else. So what happened to the pain relief in that case? Well, in the group that either got the placebo or the naloxone, their pain went up by 6 to 8 out of 10. And in the group that got either the placebo, the naloxone or the fentanyl, their pain went down by 2 out of 10, irrespective of the injection that they were getting. So the way that these guys phrased it, Gracely and his colleagues, were that the physiological action of the treatment administered is influenced by the expectations of the patient and especially of the clinician. So to me, dry needling is a complete waste of time. It's nonsense. I think it's nuts. I think it's hocus medicine. But I see my clinician colleagues doing it and getting great results. It just never works for me. It's not the actual sticking the needle in the person necessarily that makes the difference. It's the fact that as far as that clinician is concerned, this is going to work, and there's something about that therapist-patient interaction and engagement which makes it work. Pull teeth out, it hurts irrespectively. Well, look, placebo. We can't honestly be giving a placebo as a treatment to our patients in all honesty. We need to be doing real medicine here. Turns out that not only explaining pain makes a difference, if you just explain the placebo effect to your patients, they get better. So if they understand, I'm going to give you a treatment that has no physiological effect, okay? And you're going to feel better because of it, okay? And they do. I think we've been patronising our patients for too long. So let's come back to the start, and we've only got a couple of slides to go. Think about our guy here again. He's our 28-year-old. What are some other things now maybe that we might need to think within this framework? What country has he come from? What are going to be the consequences of him missing a whole bunch of training or playing? This is his career. Could this be career-ending for this guy? In this country, is he going to be kicked out of the country because he can't do this? Now what happens to his ability to support his young family? How's this guy been sleeping? How are things between him and his wife right now? Between his teammates? Between everything else that's going on? How much of a threat does he feel under from this thing that they can't tell me what's wrong? No one's been able to find actually what's wrong. All they tell me is that I've got chronic anterior pain. So all of this different stuff that we do here, I think we need to think about it, is that what the patient's actually thinking is, what's wrong here? And that comes down to 2 questions. How much danger and how much safety do I have? How much can you give me? And how much danger are you giving me? So I think back to things that I've said to patients over the years that I can guarantee have made them worse. So how safe am I making my patients feel by saying different things like this to them? And what are the things that we're doing in our ordinary everyday clinical practice and engagement that are entirely justified, that are making things worse? And do you think we can make a difference by taking this on as part of an aspect, as an adjunct towards our therapies? Now, kind of the final caveat that I'd have with this is, where there's been this big fork in this road, the guys who've gone down this pain science fork have basically said, look, forget about pathology completely. And in my heart, I think they're still wrong. The pendulum has swung far too far in towards that direction. But for us, the pendulum has been far too far in this direction, and we've not considered any of this stuff at all, and it's been to the peril of us and our patients. Thanks very much.